So welcome, thank you very much for joining us here today. So I'll just do quick introductions to the team that we have on our Health and Care Advisory Board. We're very honoured and privileged to have you guys join us, and I think really thankful that actually we'll be able to make some great contributions and understand the challenges faced by our customers as well. So on the far left, we have Dr. Harpreet Sood, GP partner, South East London, health technologist, former advisor to Simon Stevens, NHS England, and deputy CCIO. So thank you, Harpreet, for joining us. Then we have Professor Joan MacDonald, consultant psychiatrist, former Trust medical director, former national clinical lead for IT. And then we come to Dr. Rowan Sill, GP partner in Northwest Leicestershire, clinical IT lead since 2017 in CCGs, and now CCIO in Leicestershire ICB. Thank you very much for joining us. So one of the things that we wanted to discuss, obviously with the upcoming 10-year plan, not sure there's going to be too many huge surprises. I think we know, the direction of travel. I think the government have been quite clear on, the three priorities, but just wanted each of the panel to kind of really discuss what are those priorities, the challenges, and hopefully the opportunities that it might present going forward. So if we could start with the left with Harpreet, if you could mind leading off for us.
Thank you, Laura, and great to be here, and nice to see some familiar faces. So, look, I was asked if I could be both candid, but at the same time, hopefully positive, but also think about where the opportunities might lie. So I think it's really an interesting backdrop that we have in front of us today, right? We've got, obviously, the work in the 10-year plan happening, and the expectations are one of the biggest change programs that was outlined by Steve, probably since 1997 or 2010, right, in terms of what the expectations are and what this current administration wants. But the other backdrop we have with it is that it's probably one of the worst financial times since the financial crisis of 2008 in terms of really where we are from an economic perspective, but also the competing priorities we are facing, not within Department of Health and others, but also within all the different departments across Whitehall, in particular defence. So when you put that kind of context in place, I think the rhetoric that's been outlined with the 10-year plan to what the reality is, I think is still quite far apart. And from my personal view, I think really that this government is spending a lot of time and resource on this 10-year plan. It's really engaging everyone. But the big question is, where is it all going and what is it going to outline? And the reason why I say that is because in 2014-15, we published something called the 5-year forward view. And my view is that we could probably quite easily change the dates around, and what was said in that document could quite easily be the 10-year plan today, which is still the same things that we're discussing. How do we do more prevention? How do we invest more in technology? But also, how do we take care into the community? And so the reason why I'm outlining all this is that I think the 12, 14, 15 months that we spent trying to get this 10-year plan really going, A, it's very hard to plan 10 years, but B, actually, we could really get on with it. And I think that's where, for me personally, is a real opportunity, is to say, yes, we can wait for big government papers to come out, we can wait for the strategy to come out, but actually, this is really the time to accelerate, because the messiness that we might be seeing in the centre actually gives a lot of air cover to get things done locally, because no one's really looking or no one's really interested, and I think it gives us a more of an opportunity to do something exciting. So that's kind of my starting point, and I'll talk more about some of the stuff we're doing in primary care and in community throughout this panel discussion, but that for me sets the plan to say, yes, there's a plan in place, but actually the opportunities for me are to just crack on with the great stuff that we've seen this morning and the great stuff you guys are all doing, and we heard about some of the great stuff that's happening on my particular table, rather than necessarily wait for this big document to come out.
Thank you, Harpreet. If I could move on to you, Joe, in terms of what you see as opportunities and or challenges in this time.
Yeah, well, it's a very difficult time for mental health service at the moment. I feel as a consultant psychiatrist that mental health is where dentistry was 20 years ago. It's at a tipping point where dentistry became available for those who can afford it and unavailable to those who couldn't. I feel that mental health services are going to end up for those who can afford it or for the loudly mad. And everybody else in between is going to wait 2 years for an appointment. unless we can do something about it. The 10-year plan, we were hoping actually when we set this session up that you'd all have a copy. You might all have a copy of the digital bit because it's been widely leaked, but I would echo Harpreet's call to arms really, is that we need to get on now. When I was a trust medical director, we did the old-fashioned time and motion stopwatches in clinics, and we found that 25% of a consultant psychiatrist's time was spent seeing patients, and 75% of the time was spent doing something else. And a lot of that something else was 63-year-old psychiatrists doing one-finger typing because they got rid of his medical secretary, and he's now the most expensive clerk in the world, and also quite inefficient. As National Clinical Lead for IT, I was responsible for inflicting Servolex Rio upon many of you, and the extra burden that EPRs put on people. I've joined the Access Group recently because I think we're about to hit a tipping point where actually the machines are going to start to serve the clinicians, and things like smart notes in Rio will absolutely move that 25% of clinical time needle. And I think with these tools, we can save NHS psychiatry from going the way of dentistry. But we need to crack on and frankly not wait for the 10-year plan, which from what I've seen of it so far, and as I've said, it's widely leaked, come and see me at lunchtime, it is much like any 10-year plan in IT, it'll be out of date in 12 months. And it'll have to be rewritten because the technology is moving that fast. I've already heard on my table integration of Rio and Silver Cloud. Put your hand up. One of the things that we're going to have to do is transform some of what mental health does in terms of automation and self-service. If there's a 2-year, 3-year waiting list for, I don't know, CBT, we can't leave them with nothing. We have got the technology to serve up something that they can help themselves to. And I feel that's where I think Rio needs to go next, is the production of these kind of collaborative platforms where the patient actually can get some self-help. Otherwise, we drown and we go the way of dentistry. That's probably enough for me.
Thank you, Joe. Bowen.
Well, I just want to say thank you for allowing me to speak today, and thank you all for coming, because I think it's one of those pivotal points now. We've heard from the 10-year plan. I'm in an ICB and ICS. We don't actually have Rio, so I'm amazed that they've asked me onto the board. But it's the other stuff that I really like about Access, that really, the integration. And I'm going to start talking about local authorities, because I think we've got to at some point. We're all here, we know what an ICS means, and I think all of us, as we start talking about healthcare, we kind of become more fixated on that. So the blueprint that came out a couple of weeks ago, it's really ambitious, let's face it, for the ICSs. It reshapes integrated care boards into these leaner, more strategic commissioners, but has that really strong focus on population health, prevention, and the intelligence behind digital. For those of us in the room that are in digital and data leadership roles, this really does present a massive opportunity to elevate everything that we do. But at the same time, look at the complexity it brings with it, the risk and the disruption that's all coming at the same time. We're all being asked to do more in ICS's providers as well. But at the same time, the system, we've all heard, they've got less and less money to do this with. So there's lots of responsibilities on us as digital teams. We had a fantastic talk on our table about how much you have to do with the systems you've got to make that work locally. And that doesn't come without a time and a cost pressure. Everything is dependent on that to help your clinicians work. And then, as an ICS level, I don't know how many people are from ICSs that are in the room today. We've then got to look at the analytics, the risk stratification, the population insights that we should have been doing for 10 years probably. But because of firefighting, because of operational pressures and all those other things that come with the NHS, we've not got round to it, and now they're asking us to do more when we've still got all of those operational pressures. So it does leave us in a bit of a precarious position at the moment. We're asked to lead the digital strategy, but we're going to hand off some core digital operations to providers like yourselves, and it does create confusion. If we don't think about it now, we're risking that undermining of capability and the confidence that our clinicians have in us and patients. So one thing I want to think about today, and us all to think about, is the stability of our workforce, our digital workforce. They're already stretched. Let's face it, I've heard lots and lots of stories today, but I can tell you thousands of stories from my years in the role around how we just can't get round to everything that we want to do. And where does the future lie for us all? We're going to have to bring talent in, the 15 and 16-year-olds that we were talking about earlier. We want them to come into the NHS. We want to give them careers that they can really shine through. And it's only really working with bigger providers like this that want to open their doors to help that I think we're going to get there. I mean, the real worry that I have, I'm going to bring it back to the integration that we should be having with local authorities. That's the biggest worry I've got with this new blueprint. That true integration around the public sector joint commissioning, sharing data and holistic care depends on that trust, the continuity and the shared infrastructures. So those local authorities, they're not simply just going to do it because that's what they've been, that's what the mandate is. It needs teams to be able to help them come together, and they've got their own pressures to think about. So if we can't offer that stable digital interface, the shared intelligence, then the long-term ambitions might be difficult to realise. There's issues around patient safety as well. There's thousands of letters that don't get to where they need to get to, the transfer of care safely. I'm about to go on to a meeting for Midland CCIOs in the lunch break to try and explain the position we're in and the worry that I have around patient safety and risk that brings to clinicians, GPs, and the patient themselves, of course. So I think us as digital leads in our areas, we really need to protect our roles and make sure that we make sure we've got a really strong case for those as pressure hits and cuts hit. But if we've got the right infrastructure, I think we could do it. So the things that I think we ought to prioritise are probably the clarity that we have around the governance of the digital role. And that just means that we've got to come out of our providers and talk together. Those ICS teams are going to be more lean, but we need to make sure that we're at those meetings where we're talking about system operations and how does our shared care record work for us? How do we get that data up to the clinicians that need it at that point in time? And we really need to safeguard those relationships we've got with local authorities. I know I keep going on about it, but if we're going to do this properly, we've got to keep adult and children's social care on our side, mental health, etc. So that's really what I wanted to talk about. I've probably gone on a bit, but I think it's so crucial, this blueprint that's come through. All of us are looking in our individual regions, ICSs, thinking who we're going to merge with, how it's going to work together. It's a significant distraction, let's face it, and there's going to be more and more pressures on money. So I really want us as digital leads to come together and think about that properly.
Do you think it's frankly weird that we've delegated digital leadership down to the bottom of the pyramid when most of the gain is in the sharing of information between organisations? Do we need to push back on that? Well, it's not even in the 10-year plan, is it? What's not in the 10-year plan, the ICBs stopped having anything to do with digital, and NHS England got abolished. And none of this was actually in the 10-year plan. I do wonder what other things that aren't in the 10-year plan are going to land on us and perhaps make the integration, the genuine integration of care more difficult. But it just struck me as a weird thing to do.
Well, I mean, is this what they're trying to make us go towards, the single patient record? I think that's probably what's in the background, isn't it, at the national infrastructure stage. So is that part of why they're doing what they're doing? Obviously getting piecemeal information out, we get a blueprint for an ICS, but we don't understand completely what the neighbourhood system's going to look like.
Yeah.
We don't understand completely what the national infrastructure is going to look like. So we've got a bit of the middle, but we're yet to
Neighbourhoods aren't
understand.
defined, though, are they? We don't know how big is a neighbourhood.
Look, I think just on that, right, and I think there's... How many GPs in the room, by the way, just out of interest? Okay, one. Well done. Okay. Well, let me explain to you what a GP does. So a general practitioner, right, and I think this is quite important for us to understand, because my role as a general practitioner, but also the primary care side of things, is changing considerably, right? I would say about 20 to 40% of my workload today is social or mental health related. However, I am not engaged or interacted with my local community providers or my mental health providers to the level that I should be at in order for me to provide good care for my patients, right? We see a patient and we'll refer and we'll just wait. And that for me presents a real opportunity to say, if we are really doing neighborhood working, yes, I can wait for someone to help define it to me, or I can just pick up the phone to the local consultant or the local team and say, look, how do we actually work together? Yes, we can share information via email, we can share information through protected ways, but we just need to get on with it, because if we are going to wait for someone to define, we'll spend 6 months trying to do a scope of work, then another 12 months trying to define a strategy, then another 12 months trying to do definitions. But so many of us are already doing neighborhood working, right? Same with social and adult care, right? I now every other Friday do a home visit session with my healthcare assistant, and whenever I go to my home visit, I see the access folder and the access notes there. But again, it's an example of how we are defining and redefining the way we manage frailty patients, but also how we work closely with social services and social care colleagues. But again, this is already happening, and I think waiting for someone to help define that will just take forever. So that, for me, are the quick win gains to say, actually, how do we come together, whether it's the ICP level or whether it might be with 3 or 4 big federations in that local patch, and say, this is the reality of care today that we are offering up, well, patients need and what their families need, and this is what we need to offer, because that's really where the demand is, and that's really where the opportunity is.
I think on that point, I'm going to come to questions, so be thinking shortly. But I think on that point, you mentioned about the prevention agenda. It's nothing new around kind of community working. But how do you think actually people in the room can take away kind of projects that are already successful, or share knowledge, or work with partners and suppliers? What would be the kind of the advice for next steps?
Well, my advice would be all the change agents and advocates are in this room, right? And I think if we can't do it, I mean, I'm not sure who can. Again, we've heard countless examples of people doing great work in their community trusts, in their local sites. My particular table, we were hearing about virtual wards, EPMA, and other things. I mean, we are already doing that work. And again, if I take virtual ward policy, right, the policy that came out nationally. By the way, I'm not against what's happening in the centre. I believe there's some element of what they do is good, but ultimately, and when it was defined, what virtual wards has changed considerably to what actually the reality is of how we deliver it in a local setting, and that only comes in when you actually start implementing, start realising where the acuity is, start realising the different patient needs and the patient demographics, but also how you would work on that together. But again, it allowed people to grasp that and really go for it. And of course, yes, I get the funding matters and you need some element of funding to do this. But there are ways to work around it that we can actually make a lot of these things happen. But that's just an example. I think that if collectively we put all our heads together and just did some of this stuff that we're outlining, I think we'll make a lot more progress in the next 12 months than we will for waiting for national strategies to come out. I
think we have to find a way for this community to come together and share, best practice. I'll probably be a little more scathing about the centre than you, Harpreet. I was only there 4 years. But I don't think they can keep up. I don't think they can keep up with the process of technological change that's going on right now. And I think it's on us as a end-user community of a particular system to make sure that we are sharing best practice. There's a world of IG pain and clinical safety case pain to go on around smart notes, which might save us a great deal of time and money and make life a lot better for patients. But if we each go off and write our own clinical safety case and do our own documentation around IG, I think we could put our heads together and save ourselves all a great deal of work and get on a great deal faster to more efficient use of our systems.
I really do hope they've got that thinking when it does come to regional and national infrastructures, because one of the biggest things that we're not brilliant at is the DCB 0160 and the amount of work and time it takes to do that hazard log and make sure it's fed back in the right way and collecting all of that resource. It takes time and it takes a lot of effort. And actually, I think a lot of it slips by the wayside, doesn't it? We've got new and amazing kind of technology, software in general practice, probably more so than anywhere at the moment. It's like a Wild West out there for new products and things that will help us on our admin, that will help us code letters that come from you guys into our system. And of course, it's the admin involved with curating that patient record that we have right now. That, you know, I'll say our admin teams are on that constantly. There's 300 or 400 letters every 10,000 patients that are coming in every day, every other day. So there's so much work that goes into just keeping on top of that patient record. There's got to be something else that we can do about it. Are the shared care records the answer? I think the way that they've brought the data together might be the answer. It certainly works in some areas, but then you've got variability between some areas doing one thing and others doing another, and depending on what those teams have requested, what they've asked for, that's what's going to be surfaced in the record. So there's lots of variability, and you can kind of understand the rhetoric around the single patient record when it comes to things like that.
It's seductive, isn't it?
It really is.
Let's get rid of interoperability and all that difficulty. We'll just have the one record. Well, I was medical director of the Lorenzo delivery team 15 years ago, which was a single patient record program for 30 million citizens in the North Midlands and East of England. We spent 3 billion and ended up with nothing. So I'm a little wary about that single patient approach. I think we need to build on what's a pretty good installed base, actually. Shared care records, electronic patient records across most of the estates, all of general practice. But I think really interestingly, I think communities like this have the opportunity to take things forward. And maybe actually communities like this are the only people who could properly govern something like ambient voice. Because you only actually get to understand the risks and benefits of ambient voice by doing ambient voice. You can't read about it in a book anywhere because nobody's done it yet. So it's on us.
Absolutely. And we shouldn't forget about the NHS app. That seems like yesterday's news now, but actually I still believe that, at least from general practice and primary care's perspective, it's a tremendous tool that has so much potential, not only to access records, but actually give patients and empower them with the information they need. And it seems like no one's really talking about it now because the next big thing is single patient record. But nonetheless, I think we can solve the single patient record through the NHS app.
It's interesting because NHS app is sort of a single patient record, isn't it? Because you can see quite a lot of stuff in there. You can order your prescription in there. They're talking about appointments. So is it the same or are they building something else? I don't know. Summary care records, sort of a single patient record. Do you need them both? Does one of them get cancelled? I don't know, but we seem to be developing a third national patient record system. Only this one's really vague and bigger and more ambitious than Lorenzo, which cost a great deal of money.
Some of the talk that we had on our table was about the basics, the absolute basics. That's basically what my job is as CCIO for a system, is making sure that I capture all of those patient safety problems, the communication between these EPRs, Rio into TPP, let's say, Rio into EMIS, the communications that if they're not done in the right way, this is basic everyday stuff that clinicians and admin teams in all of your kind of trusts and also in general practice are all working on absolutely all the time. If anything goes wrong with that, there's an issue. There's a patient safety issue. Somebody's not handed over the information they need to. There might have been an action there. And again, I'd say as CCIO in a 1.2 million, it's not a massive ICS, it's probably average. But I can't get on with innovation in the way that I really want to get on with innovation, knowing what's, we've been presented today and what's around the corner, because I don't feel that we've got the basics right between those EPRs and the way that they interoperate and the way that they they work at the moment. And I really do hope if something comes from the top, and we're obviously going to try and influence what does happen, is that interoperability, opening up those borders and making sure that if somebody's coded it in one area, in an acute trust or a mental health trust, actually that same code is absolutely relevant. It can pass straight through into another system without it having to be transcribed again by a human, and that all of that waste of effort and efficiency. That's really my driver, thinking about back office function. I haven't even mentioned all the other stuff that can come along with back office when you're looking at things that we've been presented earlier. But those are huge, huge benefits to both patient safety, clinician burnout, and us looking at a more efficient future for the public sector. I'm going to keep saying public sector because I think we've still got to bring in those local authority colleagues at the same time.
Awesome. Thank you very much for that contribution so far. Just opening it up to any questions, if anyone has questions. We have one at the back. If you could just say your name and where you're from as well, that would be really useful. Thank you.
Hi, I'm Lucy Journier from East London Foundation Trust. Question to the whole panel. Do we really believe that the 10-year plan is going to have much innovation in it? For example, you spoke about neighbourhoods. Isn't that a reimagined version of the primary care network? Excuse the pun.
Harpreet, did you want to take that one to start?
Well, I think you know what the answer is going to be, but yeah, exactly right. I just, again, you know, when people don't know what to do, they cause distraction by reorganizing, right? And I think that's exactly what we're seeing playing out, which is in some ways disappointing because this current administration has had a lot of time to think about some of this stuff, and it's not as if they've come in fresh. And I think it seems more political at this point, where Treasury versus Department versus others are playing with each other rather than thinking about what this means for the system. And frankly, the abolition of NHS England was one way of doing that, is to say, here you go, here's something for you if we get something back, that kind of way of working. And we'll see, look, the spending review of the next few weeks when it comes out will determine a lot of this, but you know, we're about to do our 5th life science and strategy review. I mean, the number of times I've heard a life science and strategy review coming through and accelerating innovation across the NHS. I mean, we all know what needs to be done. You know, Alan later hopefully will present some of the stuff around life science and data analytics. I mean, there's so much richness out there, and I just think we can really crack on. And I think industry's hungry for it, investors are hungry for it, the public are hungry for it, but I think we're just caught in between this crossfire at the moment, and I believe that, yes, there will be some element of innovation in it, but I can't imagine it being a huge amount.
Declaration of interest. I'm a card-carrying member of the Labour Party. I have been all my life, and I am massively disappointed that we didn't have a 10-year plan, or frankly, I would have taken an 18-month plan for the NHS ready to go, and instead we got a big consultation on a website where every member of the public could have something to say. We know what happens when you ask the public. You get Boaty McBoatface. You don't get a coherent plan to fix a very broken NHS, unfortunately. So I'm massively disappointed.
Although I do think we ought to involve our public, but it's the way that you do it. It's the way that you gain those insights, isn't it? And I think if you're hearing, I'm trying to get in our area, I'm trying to get almost like a patient safety case for digital. Let's say somebody's calling in distress and it goes through to 999. 999 realise that it isn't a 999 and they transfer it over to 111. 111 then rings the patient, talks to them a bit. There's another handover of care, the digital handover again, and then they're handed down to perhaps an urgent care centre, or just before the urgent care centre, a clinical navigation hub. They have to go through the story again. And then so on until they reach that point of care. How many times has that patient said the same story over and over again? We know we've probably dealt with our mums and dads, our grandmas and so on. We've tried to navigate that system for them. We know we've gone in with them and we've sat by their sides and we've relayed the same story across. My mum's got dementia. I've had to say the same thing over and over when I'm talking to every clinician that comes to see her. And you just think, oh, it's this day and age, we've got amazing digital systems. The stuff on our smartphones now blows your mind away that it's so easy. Why is it not relatable in the healthcare and the social care sense? Why can't we do that yet? So it's talking to people like Access and other providers that are big enough to actually listen and big enough to start to think about what's that patient journey like? Can we make it easier for patients and easier for clinicians? And I've never really done this before with industry. I've been in digital for many, many years, and everyone's been knocking at my door. And I think, well, actually, that I've found with Access, and I've heard a lot of things about what Access have been doing in the past, but this is the first time I've felt somebody actually wants to listen and make a difference. They're UK-based. We're not going out to another country to try and find our solutions. We're actually starting to think about where's our tax money going, where's our jobs going, and how can we prop up the UK? And really, that's what we should be doing, isn't it? We're all in it to do that. We're all in it to make our country come right.
Exactly. I mean, just going back to the lady's point again, right? One of the things to be really clear about, you can't prescribe innovation, right? You can't put a comprehensive document together and say this is how you do innovation. Innovation will come through pain points, things that are really struggling in the local community or wherever it might be. This morning I was reading about these new ARC mental health centres that have been developed for adolescents and teenagers because this one particular gentleman and his wife, they took their teenage daughter to an A&E and they were just shocked by what they were seeing, where actually having their teenager in an A&E setting just didn't make sense. Anyway, they went around and developed this new centre for mental health for teenagers where there's no reception, you walk in and there's a great facility. But that's the kind of level of innovation I think happens when you really, either something strikes you or you have the right ecosystem in place or you have the right partners or the concentration in place. And I think, just as another example, right, a few months ago I was on a continuing glucose monitoring patch, wearable. And I did it just for insight. I wanted to know, what was causing my spikes, including food, but also various other things in my life. But what could be doing that? And remarkably, super interesting. And it gave me a much better understanding of actually how I can control my glucose levels, but also avoid these many spikes that actually ultimately lead to prediabetes and diabetes if you're not solving them. And, so I'm in Peckham in southeast London. And I have a considerable amount of high-risk patients, but also those who have family history who may most likely will go on to develop diabetes in the next few years. So I called up NHS England and said, look, why don't you give me 500 to 1,000 continuing glucose monitoring wearables for my local population? I'll put a coaching service around it. I'll stand up something. And this will be a really good example of innovation and prevention. And the answer I got back said, well, there's no evidence that's going to work. Continuing glucose monitoring patches only for those who have diabetes. And it just made me think, hang on a minute, it was too late by then, really, because if they've got diabetes, A, we're not doing prevention, but where's the innovation in this? So my mission, and by the way, if anyone works for a Abbott or a device company here, please speak to me, or if anyone's got any spare money, because I'm still on that mission to get 1,000, and I've got a contribution of 250, so I'm heading the right way. But to get them out, and that's the kind of level of thing that I think if you really realize what your pain points are locally, if you have a level of understanding, energy, and want to make it happen, I think that's where it's going to happen.
Thank you. Questions? Anybody else got a question? Just here, please. Thank you. Just name and where you're from as well, for the benefit of the panel.
Hi, Lucy from Cornwall. I wonder whether or not, rather than focusing on the 10-year plan, we should focus on real work that's done that we all know to be true, like the Darcy review. That's where I think we should be looking at, because that's a fact, that's research that's been proven. That's what we should be doing. It's around prevention, right? Moving care closer to home. The only problem we've got is that you need the bean counting and the money to change with that. So we can all have these big ideas and all want to do these things and join everything up, but until you change those two fundamental things, everything else is 100 times harder. So for me, that's the crux, is how do we make that happen as NHS colleagues? And I kind of want every chief exec in the country to go stand up, stamp their feet at the Treasury and go, stop giving us capital, sort the revenue out. Yeah. Because all of this stuff is subscription-based models now. Yeah. and yet that isn't what we've got funding for.
So moving closer to home, but actually how do the finances follow the innovation and the opportunities? Rowan, is something you'd like to answer on that one?
I've got some in Leicestershire, we've got a fantastic provider company that the ICB and the IC, they've been trying to kind of take away some of that acute trust waiting list and you know, make it happen with community providers closer to home. And what's happening this year is that they're losing contracts left, right and centre because of the instability in the ICS. They haven't got the funding that they used to have. And look at what's going to waste. All of that stuff that was in the Darcy report, that's in the 10-year plan, the 3 points, moving it closer to the community, and we're losing it all because of the instability that we're seeing, the lack of financial, I think it's the financial trust that we should be giving our local, you know, our systems that know what it's like in that area. They know what the pressure points are. They know where, you know, we've got huge communities. They've got the we've been doing population health management for 10 years, and yet we're trying to still get that funding to try and keep it going, A, and B, make it work into real outcomes for patients that are in these really deprived areas that we've got in our area. So I think I'm absolutely with you. We need to get the people at the top to understand these things have been done. We've got some really great evidence and outcomes. Come on, let's just keep going with trying to fund the ideas that really make a difference.
That longevity and sustainability. Yeah. And
to be fair to the 10-year plan draft that I've seen, the capital revenue nonsense is called out, and it's also called out in Darcy as well. So I think there's an acknowledgement that in a cloud-based world, investing in bricks and mortar for any project is maybe not the way ahead. So I'm hoping that there is, from my government, some sanity coming in that area, I hope.
Anything you'd like to add, Harpreet, on that point?
No, I think it's all been said.
Awesome, thank you. Any questions from anybody else in the room? Anything else that you would like to cover? Don't be shy. Okay, well, while you continue thinking, I'll just go back to ask the panel about, we talked briefly about the 3 big shifts, about moving community closer to home, prevention. What do you think that looks like in terms of where we need to be to make those decisions and make prevention a reality in terms of the communities that we're serving? Harpreet, maybe we'll start with you.
Yeah, no, so look, I gave you one example, right, of what, when we think about various elements. I mean, look, I think another blind spot that I'm seeing more and more in my clinical practice is frailty, right? And I think this is one of those areas where frailty, again, to some extent can be preventable if we start living a healthier life at an earlier stage, but also if we think about both nutrition and if we think about exercise. And it doesn't mean, you know, going out and lifting, you know, 100 kilos every day. It's more about small amounts every so often, but frequently. And you know, the thing about frailty is obviously it's a complex multidisciplinary team, but actually from a individual's perspective, it's quite disheartening to see a lot of these people living on their own, where the loneliness epidemic that we're seeing also playing out considerably, which it all kind of manifests in itself. And I don't think we've ever spent a lot of time thinking about how do we prevent people getting frail to a point where they can't cope or they can't look after themselves. And the number of housebound patients that I now have has gone up exponentially over the last kind of 5 years, I would say. But again, a lot of it preventable. And it links to, you know, simple things like, I say simple, and by no means patronizing in any way, but it does require people to take more of an effort on their health and well-being over a longer period of time, because it all compounds over X number of years. But the other important thing is that actually, even if you do start in your 60s or 70s, you can still make a big difference. But again, we have never thought about, as a system, what that might look like from a preventive angle, what it might look like about standing up services or helping people manage their health better, because we often focus on, and again, quite rightly, things around cardiovascular and cancer, because these are big killers, silent killers, you know, if you think about high blood pressure, heart disease, etc. But again, you know, I think there is already a lot of things happening in that space, but it's the elderly care element of those for a certain period between the ages of 60, 65 onwards, where we suddenly fall off the cliff, that I think is going to be the next big thing. And I think we really need to think about how we talk about prevention in that group of individuals, rather than always focusing on the earlies, health checks, 40s, etc., because I think we've got good infrastructures in place that are ongoing and doing that.
Yeah, and I think just as well, like early interventions piece and
Right.
link with
Yeah.
social care.
Well, this is exactly what I was going to bring in. You can't do that if you haven't got the links to the local
Right.
authorities, the
Absolutely.
district councils. We don't know what mess they're going to be in, certainly district council-wise. But they've got the keys to unlock. They've got those community facilities that could unlock what we're trying to achieve in healthcare, which is prevention. And we've got to start thinking about it earlier. We've got to start getting the people that are on those NHS apps going, I really want to have a good go at losing some weight. I really want to get healthier. Now, if you're starting that journey, it takes you through all of the health stuff. That's brilliant, but that puts the impact on GP surgeries, etc. We've got to do weight. Why doesn't it just directly link through to the weight management services that we've got in our councils, and get them so that we've got those priority things, looking at their own BMIs that they're putting into the NHS app. It can already take out what they're going to be higher risk and go to those earlier. So there's lots and lots of different ways we can use the data that we've already got to make sure that we're including our local authority colleagues in this race against getting people to the top of that pyramid, the top of the population health pyramid. We want to keep them down, making sure you're using everything that the public sector and your own, personal resources can achieve to be able to keep it there. That's the only way that us as a public sector can get into the next 20 years and the next 30 years, because it's all going to collapse if we're not involving local authorities, even from schools ages, and looking at the profiles of those children coming through, understanding how they live in a household where they've got two really high BMI parents, and it's a thing that's going to happen to that child as well. How can we interact at that level using the knowledge that we've already got around populations and put something into that school that links them with local youth services? And this is where I think the conversation around social prescribing and that kind of area of that unlocks the potential that we've got in a struggling healthcare system, and mental health as well, that will help us achieve some of the things that we're struggling to at the moment. I know in my ICS we are not using social prescribers to the level that they could be. I mean, I absolutely know there's an unlocked resource. We talk about community pharmacies and the CPCS for, minor illnesses. Why are we not doing the same? And we haven't got that same push towards social prescribing. We haven't in our area got the platforms that will allow us to do that. We're not on, the Access Elemental stuff. We're on a different one that just completely blocks you from interacting with it as a GP or anyone else. So it becomes more of a struggle. They can't then show the benefit they're giving to their society. They can't show that because the digital platform's not in place. So I know that the positives that some of the Access group have been trying to work towards are actually showcasing that social prescription, that element of society that will help prevent mental health and physical health going up on that population health ladder. That's what we need to be aiming for. And I think it's something that's just untapped at the moment.
So just on that, right, so the two most popular members of staff, bar me, in my clinic, is firstly is my social prescriber, and secondly is actually my health and wellbeing coach, right? So both who are they are non-clinical professionals in some ways, but clinical in their own right. And it's remarkable, right? And if I go back to the example I was sharing about frailty, it's actually working with social care, social services colleagues on doing things like hearing assessments, eye check, foot check, podiatry, giving them enough support at home to make them independent, where you start seeing an immediate turnaround. And that, for me, is also a great example of preventative care where you are providing independence, right? Just because you haven't developed heart disease doesn't mean that's the only way to do prevention. There's lots of ways to find prevention. But again, it's doing exactly what you said, is utilizing the resources that we have in the community, but also the social prescribers that I particularly have and we use within our local patch. I mean, they are phenomenal, but they're also very popular.
I think social prescribing is massively important in the crisis that we have in our young people. We're all probably digital fans here, but not everything that digital has done has been good. And I think we have to seriously look at what continuous screen time is doing to our young people and some of the less positive things that they can get involved in as a society. But the ability to, I don't know, get somebody into a football club or into a music studio or something that takes you out of doom scrolling about, you know, how you look compared to everybody else is something I think we need to look at. So I think social prescribing has a massive role to play there, and maybe legislation.
That's interesting, actually. I was talking to some of our customers in the social prescribing space who were saying that the key questions are not what's the matter with you, but what matters to you when it comes to those social prescribing link workers. It's taking the time and understanding actually what's important, and that could be housing, that could be benefits advice, that could be all of these other things that might cause clinical symptoms or contribute to those feelings.
Right, but it's also linked to that understanding or having again a director of services or access to all the services that might be in your local community, right? Because we can't always go everything through the social prescriber because of time resource. But if I as a clinician knew exactly, I could often point patients directly to them. And I think again, the NHS has tried to keep up with the director of services, but having solutions that keep real time, because often you find that a service that was around 12 months ago has disappeared, and actually you're referring people there, but no one's actually turning up and no one's providing that service. So having it up to date, because there are a phenomenal number of social enterprises, B Corps, non-profits, the list goes on, voluntary organisations in local communities who are doing a fantastic job, but often they're completely blindsided from the NHS.
And we mentioned earlier about the self-referral,
right.
the kind of self-help, and we mentioned quite a bit about patient engagement portals, about what would they look like in the future. What is the kind of onus on the individual, especially with the single care record potentially coming down the track? What's the onus on the individual, and how do we factor that in as we look at things like patient engagement going forward? Do you think, maybe Joe, if you wanted to start with something?
I think it's really important that we get the community layer right, the integrated care piece right. The biggest problem, I was going to touch on this afternoon, but there's a constellation of care around every patient, and they're not in one organisation. They're not even employed quite often. So one of my mother's first ports of call, she's been looked after by the Little Sisters of the Poor. Now, they don't have an EPR, and yet they are a really important part of that constellation of care. There's half a dozen trusts involved. And what I'm hoping, one of the reasons I joined Access, to be honest, was I'm hoping that Access is big enough and got enough clout to begin to join up all of these disparate bits of the care system, which currently not only don't talk to each other, they don't even know that they're there. So that's the why for me, is how do we integrate? The NHS is not going to be able to provide it all. There's not enough money. We're going to need the Little Sisters of the Poor. We're going to need the local football club and all the rest of it. And they're all going to need to connect in that constellation of care across 3 or 4 trusts, across a geography. And I think that's where the biggest challenge for me lies.
And we heard earlier from Alan and Umang about actually the friction that actually can come introducing and joining up those constellation points, if you like. How do we steer away from introducing that friction or eradicating that friction? Is that around process, automation, to the point about digital impact? What are the things that we need to consider when we look at removing friction from those processes? Harpreet?
Well, it's gone.
Go on, Joe.
Well, I think that I think health and social care is looking for a layer of interaction. It's a bit like WhatsApp, where anybody can be in a WhatsApp group for any manner of things. So we've got a family WhatsApp group, I've got a football fan WhatsApp group, and you need to be able to put together these teams who are not necessarily all on the same side, but they are all involved in the care of an individual. And I'm hoping that we'll get to almost as usable as WhatsApp, in a sort of integrated care platform, rather than a single patient record, which I think's unreachable from where we are without a great deal of money. But I do think you can put a layer in where you can have everybody is able to contribute to the care of an individual, and you don't necessarily have to be on the payroll, because I don't think we can solve the problems with people who we can afford to pay for. There needs to be volunteers and non-profits and all the rest of them need to be brought into the system rather than standing outside it, as they often do at the moment.
Mm-hmm.
Yeah.
Just the join between social and health. I mean, when you're looking at an elderly person that's going for the first time through the dementia assessment process, that's all being done in the medical sphere. So you've got lots of lovely notes, rich notes from your mental health services. You've got some from the CPNs working in the community. You've got all of that wonderful evidence there. Lots and lots of capacity assessments done over periods of time. So they're done really, really well. And then, of course, your patient loses the ability to look after themselves, goes in as an emergency, let's say, and in the hospitals, because they can't see any of that information, they can see bits of the GP record. I think, you've got your GP Connect feeds and things like that, but what that doesn't carry is the rich data that sits behind that overview that then helps your social care colleagues in discharge centres in the hospital go, hold on, but we've been through loads of work with this lady, and she's now got to the point where we need to start thinking about other things and introducing more care, or she's at the peak of her care at home. We need to start thinking about placements and what does the family think, how are they? So that assessment, every single time that lady moves a ward, because they may have not got the room or they need to get people out, another person comes and does a capacity assessment, and another person, and every single time that work is being duplicated and triplicated and all the rest. So look at the inefficiencies you've got without information. Information now is what I like to think of what Glaxo were doing with drugs 20, 30 years ago. Now it's about information. That's going to be what drives us forward into the next century of what we're doing in healthcare and population care.
Yeah, well, exactly. Just echo that, right. So I think it's really interesting because about a decade ago, when I was at NHS England as a deputy CCIO there, the conversations we were having was, how do we get hospitals and mental health trusts on an EPR, right? But that conversation has now moved on considerably, because nearly 90% of trusts do have some element of EPR or have that in motion. So we're moving into this new phase now with the advancements that we've seen with generative AI and tools that are being built on EPRs, and the fact that you don't need as much resource or hardware. You don't need expensive kit. You can build things quite quickly and get instantaneous feedback of whether this is working or not. But also with all these cloud-based solutions out there, we'll start seeing some really excellent workarounds, and we've already started seeing that with clinicians, people working across the system who are developing things that actually work for their local pain points, but also the local challenges that they're facing. And I think we're moving into that era now. Over the next 5, 7, 10 years, we'll see a lot of this stuff happening. And I'm hoping if we're ever invited back in 10 years' time, our conversation will be very much different to what it is today because of those reasons.
And I think it's interesting as well, the point around data and transforming what is a pool of data to actual insights and actually being able to act on. Alan mentioned earlier about how much data is being created, but actually unless it's usable, unless we can do something with it, then really we're in no better situation for having all of this this data to hand. Is there anything that you'd like to add just around actually how do we make data usable and insightful?
Well, it's that 3 a.m., isn't it? If you're an admitting doctor, or you can have a psychiatric hospital and the patients come in, you've got the wealth of it. You've got so much information. If you're on a shared care record, what is it that you need to see with all of that data set that you're thinking at 3 o'clock in the morning, I've got to make this decision, I've got to work out what the risk is to me, what the risk is to the patient, how am I going to trawl through what their background, their history is, when I've got so much information I don't know what to do with, and it's the middle of the night, I've just been woken up, and I've been up for the last 10 minutes, I'm a human that is absolutely not going to spot something that probably could be something that's really, really important. How, and I think this is where Alan and his AI genius comes in, because that's what you want to know at that point in time is what's going to matter to me and the patient, and how I'm going to make this safe for us all. Because at the moment, those 3 o'clock in the morning admissions are being made, and they're literally just trying to do what they can at that point in time. There's not a lot of clinician or patient safety going into that assessment. And actually, it's all being weighted to the morning, and then they've got some more information, and they're trawling through paperwork at that point on systems that perhaps are part paper, part EPR, and then you've got your GP Connect coming in as well. But all of that stuff needs that layer of something over it that will help the clinicians and the patients work safely at any point in the time, or in the time of the day or that time of the week, whether it be weekend, weekday, when nobody's around in the middle of the night. That's when you need it.
So, Rowan, good news for you. I actually came across an organisation recently who's doing exactly that, right?
All right.
So, and again, Access is doing some element of it, but there's an organisation that sits on top of EMIS. They capture all the data, PDFs, documents, labs, radiology results, etc., and it's a search tool that sits on top of it. So I can ask it any question, and it will trawl all that data and give me the answer. So the point is, there are solutions in place. And it's just the beginning, and I think we'll see more and more of that. So your wish has been granted right here.
Well, the wish was, let's get everything onto digital.
Yeah.
But I don't think we've then accessed what digital could do for us from that point onwards, and I think that's what part of the rest of the conversation.
I'm going to get greedy here and say, I got into this 20 years ago because somebody rang me up because I was the only adolescent psychiatrist they knew and said, my 15-year-old daughter's just developed an episode of psychosis. What's the best treatment, Joe? No, I didn't know, but I'm pretty sure that the answer is somewhere in all the data. I could get it right first time, patient gets better in 3 weeks, back at school. Get it wrong, 2 years in an institution, maybe your whole life, while I spool through antipsychotic treatments. And I still want to answer that question, what's the best treatment for first episode of psychosis? And I'm pretty sure that the answer is in Rio. It's in 25 years worth of data that we need to somehow, and I know it's hard from an IG point of view, I know I've been a Caldecott guardian longer than Fiona Caldecott, frankly, but we need to find a way as a community to release the power of that 25 years worth of data so that I can say, Alexa, what's the best treatment for a young person with schizophrenia?
Don't I ask Alexa? I mean, there is technology. There is technology now. Clinical decision support tools. Clinical
Actually,
decision
Alexa
support.
might not give you a bad answer.
Well, it could be. It could be. We could just ask Access. Or
I was just hoping that she was listening and maybe she'd just come up with it there.
But I just think, again, the whole sophistication and movement that we're seeing with clinical decision support tools, I mean, it's phenomenal what we're seeing in the market now. And I think it's only time will that will come.
How are we going to translate that? Because there's a lot of people here that are just thinking about waiting lists. I mean, that's the biggest problem that we've got in mental health.
Well, we need to take their waiting list down by making their clinicians more efficient.
That's it.
And that's how you get there. At the minute, mental health is in survival mode. They can't get their head up long enough to see where the low-hanging fruit is in research and in terms... I mean, Sigmund Freud was recording his sessions with patients in order to avoid writing them up 90 years ago. And we're still doing it like Hippocrates, typing with 2 fingers. That's got to stop.
Is there any final questions from the room? And yeah, over here. Thank you.
Just on that last point, that's really interesting. And I think one of the tricky things for people who are non-clinical is that training piece, you know, particularly for mental health clinicians. It's a very traditional way that they are trained, and therefore there is an expectation that they will work in a particular way when they come to the trust. And I think that's a very hard thing to change. That clinical documentation, professional record keeping, you know, that training on how to do that really efficiently falls outside of digital. You know, it's not something that we can fix, but there doesn't seem to be a movement around that from the clinical side. And I don't just think it's in mental health. I think there's other pockets of where that's problems as well. But how can we do something about that? Because until you change the mindset of clinicians of how they should be recording and documenting, it doesn't matter what tool you put in place, because they won't want to change.
You have to create a social movement. That's what you have to do. You have to create a movement of clinicians who are tired of doing it the hard way, taking ages to write things up. ChatGPT does something really quite clever when you put a psychiatric history into it. It formulates it. How many psychiatrists in the room? Not many.
There's one over there.
But one of the things that you can do is you can set it to formulate. When we say formulate, make sense of the life story that the patient has just given you, and you break it down into a number of understandable chunks so that you can then do something about it. And we are not doing that. We're not using it like that at all. But you do have to create a social movement, actually, if we want to build real change.
I think we've got to go for. I think we've got to go to the medical education. We've got to go to medical schools. It's so frustrating when we get new GPs through. You've probably got the same problem. And we have to teach them as the partners, this is how you document something. This is how you code something. Gen AI has been the biggest move forward that will ever happen in clinical since the EPR first came out, because it will take that away so they can have the clinical conversation and summarize it. I know coding's coming very soon, if not already here. The human validation is what we need. It's not the way that you do it. So
yeah, pilots in the aeroplanes. Yeah,
yeah, exactly. So I think when it all goes wrong, I still think that we need to have that medical education in place, because at some point the autopilot's not going to be there one day, and I don't let any of our registrars currently use things like Heidi or generative scribes, but I think we've got to teach it right from the start. There's got to be, this is what your health system works with, this is how to communicate, and what we're not doing is we're not teaching that right from when they get in at 18, or when they get into, you know, that is the crucial bit behind it.
I think it's teaching that responsibility, the responsible use of tools as well, like
Absolutely.
we mentioned earlier about
we talked
ethical.
about the digital literacy that our clinicians and our admin teams have. Actually, if that's hard baked in right from the start, then you've got no problem. We also talked in our table about how easy it is to use an iPhone or any other phone, and that's what 15 and 16-year-olds have got absolutely licked. Well, let's bring the two things together. It's not that difficult nowadays. Medical education needs to understand it, and the way that we teach our practice managers and our admin teams in NHS and in acute trusts everywhere, they will need to understand it right from when they're inducted. It's as simple as that.
I mean, linked to that, right, I think it's also becoming a issue of patient safety and quality.
Yeah.
And the reason why I say that is if historically, and this is not happening with Rowan and I, but a lot of GPs will just write a sentence or a few words to say, saw this patient, all well. I mean, that doesn't mean anything to anyone, right? Whereas now what we're seeing is, if you look at clinical record keeping and note-taking with some of these scribes out there, A, is super comprehensive. B, it's picking up things that you probably can't remember that you spoke about.
Yeah.
But C, more importantly, is that the rest of the team and the practice are also understanding your thought process and what exactly happened in that consultation, which then leads to when the patient's calling up and saying, what's happened to my referral, what happened to the meds, etc., they can respond, and you save time and efficiency through that lens. And it was phenomenal for me, right, when I was using this about 18 months ago because one of the organisations reached out and we started trialling it. And in my practice of about 22 clinicians and staff, when I used it, I was like, game changer, we're all going to use it. How many do you think turned around and said, I really want to use it at the outset? 2. And it was fascinating because I was like, well, why not, right? But actually, if you get to the surface of it, there's multiple issues that need to be unraveled. But actually, when they start realizing that, you can, potentially save 1 or 2, 3 hours a day if you're doing a full day clinical typing. It's leading to better quality safety, better outcomes, or whatever it might be. Then actually, the social movement element starts coming into it a lot more. But now, if I look at the GP community, I mean, I don't know exactly how many, but it's a huge number of people using it, and I think it's just the beginning to how we're going to change it. But I think the quality and safety issue is really important.
You think that's the difference as well between the digital literacy point and a digital confidence point?
Yeah.
I think the gentleman earlier asked about actually people are using tools in their everyday life, but maybe don't want to use tools in a clinical environment. And do you think that maybe comes down to actual confidence in, am I doing the right thing? Is it the right way? Is it the right process?
Absolutely, and I think from a clinical element, which is also a challenge, is that, and I don't think this has been solved yet, is that the indemnity providers are not willing to take responsibility for scribes today. And I think that's a challenge because for a lot of medical professionals, they don't feel like they're covered if something was to go wrong. And I know there is some work happening in place at the moment, but those kind of things are the ones that will lead to lack of confidence and people not using it, rather than actually this works because it does exactly what it says on the tin.
Absolutely. Any other final questions from the room before we wrap up? Awesome. Well, thank you very much. The panel will be back later on this afternoon for a different title session. But please thank the panel in the usual way, and we really appreciate thank you.